We've been dealing with how to cope and how consultants are getting on, etc., etc. But actually, the future is in your hands, not our hands, and it is really very exhilarating that the trainee group and the senior registrar group have taken on this webinar. So David Brinkman, who is the chair of the Irish Surgical Senior Registrars Group, we're very grateful to you and for your committee for putting this together. I look forward to listening. I won't be doing much interrupting or contributing, which will be a pleasant change. And I really look forward to hearing what your views are. So David, will you take over and lead out? Thank you.
Thank you, Professor, and welcome everyone to RCSI's Irish Surgical Training Group trainee webinar. The ISTG is a group of surgical trainees that represents trainees in Ireland. The committee and I have put together some of the trainees from around the country presenting on how trainees have and are recovering from COVID-19, the ill effects that has had on surgical training. Darren Joyce will start off the proceedings with how she looked at the ST1 and 2 trainee logbook numbers. That will be followed by Orla Hennessy, who will talk about how things are going at present and through the presenting the survey that we put out over the last 2 weeks and looking at how training has come along since the nadir of elective surgery. And finally, we'll have Catherine de Blackham taking us into the future and talking about succession planning and domestic fellowships and her experience of that. Kieran Ryan is going to talk a little bit about how the impending FRCS examination is going to be run, and we'll wrap it up then with a panel discussion at the end. So if I could remind you all to keep your cameras and microphones off and use the chat function to pose any questions that you get through as many of them as possible. So without further ado, Darren, if you could let us know what you found when you had a look at the logbook.
Thank you, David, and thanks for the opportunity to speak this evening. Can you see the slides okay?
Yes, thank you, Darren.
Thanks. So COVID-19 has given rise to unprecedented challenges in the fields of public health, scientific research, general practice, and hospital-based medicine. Efforts to limit the spread of the virus included international travel restrictions, prolonged periods of lockdown in severely affected countries, and the postponement of elective surgical procedures, and this practice was reflected globally. In Ireland, oncological resections were allowed to continue in selected cases, many of which were outsourced to private hospitals. Guidelines on case selection was provided to surgeons by the National Clinical Programme for Surgery. It is expected that restrictions placed on the volume of surgical procedures will impact on trainees' operative experience due to reduced overhead. We compared this with the control period of the 12th of March 2020 to the 7th of July 2020. We also examined the full training year from the 14th of July 2018 to the 7th of July 2019 versus the 14th of July 2019 and the 7th of July 2020. The first time frame was chosen in order to determine the impact of COVID-19 on operative experience during a period when elective operating was particularly curtailed. The purpose of the second time period was to examine the volume of operative experience for ST1 and ST2 trainees during the full training year 2018-2019 compared to the full training year 2019-2020. So the results for time frame 1 were as follows. A total of 16,729 operative procedures were recorded during the control time period. Of these, 11,589 were undertaken by 58 ST1 trainees, and 5,140 by 55 ST2 trainees. This compared with a total of 6,223 procedures during the COVID-19 era, which represented a 62.8% decrease in total procedure numbers. 4,651 procedures were recorded by ST1 trainees and 1,572 by ST2 trainees, representing decreases of 59.9% and 69.4% respectively. Analysis of total procedure numbers performed by individual ST1 trainees demonstrated a decrease in the mean number of procedures from 200 down to 72, representing a 64% decrease. ST2 trainees recorded a mean of 93 procedures during the control period. This decreased by 63% to a mean of 34 during the COVID-19 era. An analysis of procedures according to the degree of complexity is shown in this table here. The mean numbers of procedures in which trainees were involved decreased in the COVID-19 era across all levels of complexity, as you can see. This effect was seen for both ST1 and ST2 trainees, with the greatest impact seen in terms of sub-minor with a 72% reduction and intermediate with a 69.4% reduction for ST1 and ST2 trainees respectively. The level of supervision was also analysed according to mean procedure numbers performed by trainees across each of 4 categories. These were observed, assisted, performed under supervision and performed independently. A breakdown of the data is outlined in the table. The greatest reduction in mean procedure numbers reported by trainees was in the performed independently category for both levels of training. The total number of procedures performed was also evaluated according to subspecialty. The greatest reductions were seen in the areas of ENT and oral and maxillofacial surgery. So next we'll move on to the results for timeframe 2. During this time, a total of 57,660 operative procedures were recorded during the first control period. Of these, 32,139 were undertaken by ST1 trainees and 25,521 by ST2 trainees. This compared with a total of 45,945 procedures during the latter time period, representing a 20.3% decrease. Here, ST1 trainees experienced a 14.9% decrease and ST2 trainees a 27.1% decrease. Analysis of total procedure numbers performed by individual ST1 trainees demonstrated a 26% decrease. Meanwhile, ST2 trainees recorded a 21% decrease in mean procedure numbers. Procedural complexity, although the effect was less than that observed during timeframe 1. Similarly, the impact on level of supervision for procedures was evaluated. Again, the greatest decrease was seen in the performed independently subgroup. This effect was, however, also lower than in timeframe 1. And finally, in terms of subgroup or subspecialty analysis, the biggest decreases were seen in the fields of oral and maxillofacial surgery and urology for ST1 trainees, while pediatric surgery and ENT experienced the greatest reductions in the ST2 cohort. So we have identified that the pandemic has resulted in a marked reduction in operative experience among junior Irish surgical trainees, and this is likely to be due to a number of factors. Firstly, overall operative volume, in particular elective and day case surgery, was severely restricted during the pandemic in Ireland, as was the case in many other countries. Complex major procedures, for example, cancer resections or repair of abdominal aortic aneurysms, may have been deferred due to the higher surgical risk associated with operating on patients in the COVID-19 setting. This approach was supported by the findings of the COVID Surge Collaborative, which reported pulmonary complications in 51.2% and a 30-day mortality of 23.8% in patients undergoing surgical procedures. Redeployment of trainees to other areas may have reduced their operative exposure. And it is also worth bearing in mind that significant numbers of doctors, trainees included, were infected by the virus and therefore may have required some time off work. An additional factor which may include guidance which was issued by both the RCSI and the HSE, recommending that senior surgeons should perform most procedures in order to reduce the procedural time and thereby decrease the exposure of staff to COVID-19. The impact of a reduction in volume of procedures was observed across most specialties. However, this was particularly felt in ENT and oral and maxillofacial surgery. These areas may have been most severely affected as many procedures are undertaken on an elective or day case basis, and they also have a particularly high risk of aerosol generation. So while all of the data that I've presented here may sound particularly negative, there are certainly many positives which I think we can take from the findings in terms of strategies which could be put in place in order to mitigate the impact of COVID-19 or indeed other unexpected eventualities. Firstly, trainees must be redeployed to private sector hospitals in cases where these facilities are used to create additional capacity to address the backlog or capacity constraints. Such placements must be fully supervised and the involvement of trainees in an appropriate role monitored and prioritised. Next, we must expand the use of simulation in the teaching and assessment of both technical and non-technical skills. In addition to this, it is necessary to exploit online teaching modalities to their full potential. And from experience within my own specialty of vascular surgery, we were given the opportunity to participate in online weekly teaching sessions during the initial 3 months of the pandemic. And this received quite a lot of positive feedback at our end of year AORCPs. As a result of this, there is now a structured online teaching programme which has been put in place for the current academic year. Next, it is essential that we formalise teaching in clinical decision making and clinical judgment through the use of simulated multidisciplinary teams and case-based discussions. We must also ensure the physical and emotional well-being of our trainees by putting formal support structures in place which are easily accessed by trainees at all times. It is also imperative that we develop flexible training programmes whereby periods of reduced training may allow trainees to step back from hospital-based practice in order to focus on non-clinical pursuits. And finally, we must actively manage the trainee journey to minimise the risk that training may need to be extended in order to make up minimum operative numbers. So in conclusion, the COVID-19 pandemic has had a negative impact on operative experience for junior surgical trainees. However, the experience that we gained during the first surge has been invaluable in allowing us to develop mechanisms by which our surgical training system may be fortified and protected in the face of the continuing pandemic. Thank you.
Thank you, Darren. A very objective look at how our junior trainees have been negatively affected. Orla Hennessy is an ST2 in orthopedics and trauma and orthopedics, and she's going to tell us about how the current situation is panning out. Orla?
Yeah, thanks for the introduction, David, and for the opportunity to present this evening. So I think compared to Darren's slides, my slides are kind of a bit more of a subjective opinion from trainees, whereby we basically submitted a survey and got as many of the trainees at both HST and CST level to reply as we could. And it's just giving a view overall of how trainees felt themselves that their training and education was affected during the waves of the pandemic. As everybody knows, the World Health Organization declared it a pandemic back on the 12th of March, and initially very strict restrictions came in at the time with the limitation of surgical services. This had quite a number of different impacts, both on operative times, as Darren has very clearly illustrated, but on other areas too. So a lot of institutions underwent changes in their rostering practices, which affected working hours as well as the type and amount of call the trainees were doing. In some areas, there was redeployment of trainees to non-surgical services. And a very big effect that I think everyone has felt is that examinations, study days, and a lot of courses and conferences have been cancelled. And then additionally, within people's own units, there was a lot of change to local teaching and educational practices. So what our aim was to investigate the impact of the pandemic on training, educational and operative experiences of all of the RCSI trainees at both CST and HST level. This was carried out as an anonymous survey via Google Form so that it was very accessible, and we circulated it via RCSI and ISTG to all of the surgical trainees at both core and higher surgical training levels. So which would have included up to 340 trainees. We had 2 separate data collection periods. So the original survey ran for about 4 weeks between the 2nd and 30th of May, back kind of in the middle of that first major lockdown. And then the second survey was then carried out kind of over the last couple of weeks between the 12th and 25th of October. It was distributed electronically via those emails accounts, and then we also kind of pushed it in as many of the separate cohort specialty WhatsApp groups that we could get access to. So the survey was divided up into a few different sections, just basic info and demographics, first of all, looking at where trainees were and what specialties they were training in. We asked trainees about changes to their working hours and rosters, their previous and current operative output, both pre-pandemic, during the initial lockdown and currently. We looked at their previous and current educational activities, both from the point of view of local activities as well as RCSI study days. We tried to get an idea of how many trainees has had courses, exams and conferences cancelled or postponed. And we also assessed whether or not trainees knew of or had access to simulation-based training within their own institutes, or if they were aware of how to access it. So this is just an idea of what the survey looked like. It was mostly a combination of kind of tick boxes, as well as places where trainees could make their own comments. Looking at our results then, overall, the demographics were fairly evenly spread. The more significant numbers coming actually from the ST1 and ST2 groups, but quite a significant input from the specialist registrar levels across specialties as well. And we got a similar kind of range of demographics between the two time points. Overall, in terms of the HST or higher specialist training respondents, a lot of our responses came from general surgery and trauma and orthopedics, but obviously that's partly to do with the fact that those are larger training schemes in terms of input as well. In terms of the CST respondents, then similarly enough, the higher numbers came from general and trauma and orthopedics. And then obviously one downside of this surgery is that the numbers of trainees generally in ENT and oral maxillofacial are lower, and they're obviously the specialties that would have been more affected, as Darren has pointed out. In terms of working hours, between the original lockdown and the current lockdown, working hours have actually returned to normal for most trainees across the board, despite an initial quite significant drop during that initial lockdown phase back in kind of March to June time. But overall, trainees have gone back to working significant hours each week and what they would have been doing before. In terms of operating sessions, again, these graphs illustrate quite clearly that during the initial lockdown, there was a significant drop off in operating sessions in terms of major theatre sessions, as well as post-call or emergency theatre sections. But luckily, with current numbers, these have once again come back up.
Hi there, David. Thanks very much indeed for the invitation to join in the conversation today. I'm just sharing now. If you can just let me know when you can see my screen.
Yes, that's fine. Thank you.
Great. That's lovely. Thanks very much indeed. And thank you to Darren and Orla for two really interesting talks giving the views on trainees. So I've been asked to speak this evening about domestic fellowships and succession planning in the context of my Aspire fellowship in cleft surgery, which I'm just about 2/3 of the way through.
Catherine, just before you go on, we can see your presenter view if that's if you can change it back to your slides.
No problem. There we go. Is that better?
Yes, thank you.
Lovely. Okay. Yep, there you go. So just by way of introduction and how I got to the point of fellowship training. So I'm probably one of the last people who went through the circuitous route of training with not in a run-through capacity. So I had, by the time I reached decision making about fellowship, done 3 years of SHO training, 6 years of higher surgical training in plastics, as well as 3 years in full-time research. So I was keen to pursue that interest. I also had a husband whose job wasn't really amenable to moving or taking a career break from, and 2 children in school, as well as a small baby. So I guess all of those factors were influencing my decision making. In the last half of my, or the second half really of my training in plastics, I had developed an interest in cleft surgery. And the interesting point in cleft really, and what makes it amenable and particularly suited to training within the unit where you hope to work long term, is the long follow-up for these patients. So babies that undergo surgery to correct a cleft lip and palate in infancy, their outcomes are assessed over a really long period. So speech is formally assessed at age 5. The influence of surgery And the deformity itself on facial growth, you won't really see until the mid to late teenage years. And the final aesthetic result then is really assessed towards late teenage years, early 20s. And that's the point when we'd undertake cosmetic revision, for example, rhinoplasty. So really what this means is that the first results of your first cohort of patients as a newly appointed consultant really aren't going to be seen for 15 to 20 years. So in terms of the a service and service in one centre, really the stability of the surgical protocol over probably 2 generations is necessary in order to really accurately assess and audit your outcomes. So for that reason, it's really attractive for the surgeons for a surgeon to train within the unit where you'll ultimately practice. So my training coming to the end of my scheme really coincided with the announcement of the first wave of Aspire fellowships by the HSE and the National Doctors Training and Planning Unit. So these fellowships are set up to be post-CCT fellowships, and the application is submitted by the training centre and by the supervisor. So the fellowship was put together in our instance by David Orr, Dylan Murray and Chris Theopold, who run the cleft unit and the craniofacial centre in Dublin. Ireland is quite unique in that these centres are really well integrated, and there's a great deal of expertise and a high volume of cases between the 2 units. And so bringing those 2 together provides a really rich training ground with a lot of opportunity for fellowship between the 2 specialties. So the document was designed so that fellows could be recruited for either cleft or craniofacial surgery, depending on where the need lay at the time. And the initial fellowship for which I applied was aimed with a very definite succession plan within the cleft unit. The fellowship was designed around the core competencies demonstrated there on the right. So the fellowship was accepted and received funding from the NTTP and then was advertised through RCSI. And I'd like to really acknowledge the support of the college for the fellowship, in particular Surgical Affairs Professor Trainer and Kieran Ryan, whose support of all of my endeavours through the year has been really appreciated. So I started the fellowship in July of last year. My week is divided mainly between Crumlin and Temple Street, with 2 days operating and 2 days of clinic. I also have operating lists in James's and clinics there for the adult part of our cleft practice. I have a day of research every week as well, and coming into the fellowship I had a number of collaborative projects ongoing with colleagues in the United States and in the UK, and the plan was for me to meet with them at various meetings during the year and keep those projects going. The clinical side of the fellowship was also to be supplemented by a 6-week observership in the cleft unit in Uppsala in Sweden. So everything was going really well and according to plan, like everybody's life, until March, at which point all elective cleft activity ceased for a 9-week period. So what I experienced during that time is really as what Orla and Darren have described, and as the literature would suggest happened for a lot of fellowship training around the world. So people talk about, obviously a fall off in elective caseload, prioritization of malignant disease, which we didn't fall into, albeit that cleft surgery is extremely time dependent. Then people describing the rescinding job offers for consultant posts following fellowship, fellows being rediverted to areas which really weren't relevant to their specialty. Also some positives, however, an increase in research and didactic teaching activity, and also increased use of online interview processes and the suggestion of mentoring going forward into the early stages of one's consultant career in lieu of the experience potentially lost at fellowship level. So I think that those are positive developments and something to certainly be borne in mind going forward outside of the times of pandemic. So what happened to us? Well, as you can see, we moved on to Zoom like everybody else. Our journal club activity increased in frequency, and we got a really interesting insight into each other's natural habitat, as you can see. I also took our research activities online, and in spite of not making it to any of my international meetings, we managed to coordinate Zoom meetings across 3 time zones to keep our research projects moving forward. I also managed to complete a supervision of a HRB summer student, which had been planned previously, and we managed to just adapt the project to be supervised remotely, and that worked out really well. We also did a lot of work around policy making and contributing to strategies within the hospitals for COVID testing of our patients when we came back to surgery, and we did some investigation about the feasibility of operating in PPE in loops and in the microscope, and we did that through access to the Surgical Skills Lab here, which was a really great opportunity. So we were delighted after all of that to return to the clinic after a 9-week break, and also back to the operating theatre in particular. So I had a look at my logbook again in preparation for this evening, and I'm really glad to report that everything is really on track, and my numbers certainly stack up well in comparison to colleagues who've been training abroad during this time. So at this stage, I've probably 150 cleft cases logged, and of those, at least 90 are as first surgeon performing the procedure, and more now moving to, as you can see in the picture, with the consultant unscrubbed and passing comment and taking photos. So moving forward from here, my fellowship was very much devised with a very definite succession plan in mind. And really the response to that, when we talk about it within the plastic surgery community and the broader surgical community in Ireland, has been really positive, with a lot of people asking the question, well, why aren't more people doing this? Unfortunately, the literature is quite sparse in the area, which would suggest that perhaps we don't do succession planning as well as we should. And I think, I mean, an ongoing theme that's come out of these webinars over the last few weeks is that if the pandemic has done anything, is that it's really highlighted our vulnerabilities as people and as a profession. So I really think that now is certainly the time to think about succession planning and to really ensure the future of our recruitment and the continuity of care for our patients. So as I reflect on this year, I think that really the most positive thing that has come out of my fellowship is that there's been, we've now created a culture of fellowship training within plastic surgery in Ireland, and I think that that's a great thing, and it's been certainly a really positive experience for me, and I absolutely hope that it continues. I would, in conclusion, I would encourage consultant colleagues across all surgical specialties to open the conversation about succession planning with their trainees at a junior stage, and I would encourage trainees to ask that question. I think it's potentially considered a bold move, but please do. It's had a really positive impact for me, and the support is there for fellowship training within Ireland, and I would absolutely encourage people at any stage of their training to consider it, and for consultants to welcome the option and encourage trainees to pursue that. So thank you very much. I'm sorry that I can't meet with you informally afterwards, but I'm happy to contribute to the panel discussion if there are questions, and obviously anyone is welcome to contact me directly if they would like to.
Brilliant. Thank you, Catherine. So, Kieran, I might start asking a quick question of you, just around maybe the logistics of setting those kinds of fellowships up. So I'm an ST5 in ENT, and I think I want to do a fellowship in whatever. Where do I start? Is it me that has to initiate that conversation, or does a consultant have to think, oh, I think my service is suitable for a fellowship? How do you get the ball rolling on that kind of thing?
Yeah, it's actually a combination of a number of things that have to happen. I mean, this is so new, and it's fantastic to see Catherine presenting how it's all gone for her. And it's actually those sort of examples is what's going to encourage more of our, services and units to start thinking about their fellowship opportunities that actually are there. I think there's, we still have a tradition in Ireland of people traveling abroad for fellowships and so on, but there are some really, as Catherine has shown, very good opportunities in our own services. And these posts we've been trying to encourage informally to a certain extent, but working with different centres to say, look, have you got these sort of posts? How would you like to develop them? The college then produced a set of standards to help with formal recognition of these fellowship posts, and that's helped people really think about, well, what the structures and requirements would be. In a lot of cases, it's people just not necessarily seeing that the opportunity is there in their unit. So I really would encourage both consultants and units and trainees to look at the opportunities that are there, see if there is actually a chance to develop a post-CCST fellowship at home. HSE are very much looking to encourage more of this. They see it as really important to retain our trainees going into consultant posts. I think that the issue of succession planning, very key, very important. And so I think it's a really important area to develop, but it is developing. I think we've had now 5 or 6 applications from various units and different specialties to have a post recognised as a fellowship post by the college, and they're using that then to recruit. And it's not always a post CCST fellowship. Sometimes it's people, it might be international trainees coming in for a year or two to get experience at a certain level and add to their training. But that's allowing Irish Surgery recruit very high caliber people into our posts, and that's obviously good for units, it's good for training, it's good for patients, but clearly we want to see more of these develop. So that's how that's working at the moment.
Brilliant, thank you, Kieran. Prof O'Connell, did you want to come in there?
Yeah, I think this is a welcome development. I mean, the truth is, you don't have to go abroad. The skills are here for very high quality fellowships, and evidence of that is that we actually have people coming from other countries to do fellowships here. That doesn't diminish the value, I think, of living and working in another country and bringing back certain particular skills, which has been traditional. But of course, Catherine has found a particular niche where everything can come together and the jigsaw fits for her family circumstances, but most especially for the units in which she's working. And you are very fortunate, Catherine, that you have had 3 mentors who are able to coalesce and to produce a particular program that is bespoke. And I sincerely hope that we will be able to increase these numbers. And as Kieran says, I have to say HSE, although sometimes and maybe more often than not, we tend to vilify HSE. Actually, HSE is very well disposed when it sees good rationale, a good business plan, and a need. Now, the other thing you raise, Catherine, and it's more tricky, is succession planning. And that has bedeviled Irish healthcare because it takes somebody to have actually retired, dropped dead, or resigned before anybody starts to initiate the replacement process. And it has been held up by many things: contractual things, category 1, 2, 3, 4, 5 arguments, CAC. Surgical sessions, all of these things all conspire to make this difficult. Now, while it would be desirable to have proleptic appointment leading on to an Aspire funded fellowship, I'm not sure that that will work in many disciplines. It may work in the particular area in which you're working, but it certainly is refreshing and inspiring to see what you've achieved. And I hope that in answer partly to David, it's a mixture, as Kieran says. It's your own enthusiasm. It's your own, you see, and it doesn't always become clear until years 4, 5, 6. that this is what I want to do. Now, the Irish healthcare system doesn't need everyone to be a super specialist. I mean, doing robotic tonsillectomy is not what Irish ear, nose, and throat surgery needs at every crossroads. It needs a lot of people who will do large volume of high quality, efficient service work. And that, if you ask me, one thing that we're not doing, we're not training to that need. And that is also seen by the HSE. So Aspire fellowships we need academic pathways as well, because very few people are finishing surgery with a PhD as an intercalated thing to CCSD. And we need that for the next generation to lead academic surgery. So many challenges out there, but David, I think for you and your colleagues, what you need to do is to decide and see what you want. And then the doors are there to be pushed open. I don't think you need to break them down, but they do need to be pushed open.
Thank you very much, Prof. O'Connell. So Kieran, I thought you might give us just a quick update. I think a lot of consultants would be very interested to see how their future, and certainly trainees would like to know how they're going to be assessed in the future. What is the story with the FRCS in 2 weeks?
Yeah, and actually in a week even at this stage, it's amazing how quick the time is flying. Okay, as everybody knows, the whole delivery of the exams, particularly the Part B or Part 2 exams, they've been put up in the air. How are you going to do this with social distancing, restrictions in travel, risk of transmission of the virus and so on? And it meant there was a whole rethink that had to be done. We're actually very lucky in one sense to be part of the intercollegiate body, which allows us to use the 4 colleges in the UK and Ireland to kind of deal with these sort of issues at scale. We also were able to use the regulatory side of things for the GMC. Any changes you make to the exam and the assessment, as it does of course have to meet the regulatory standards, because it's a key component of people being awarded their CCST and being put on the special divisions of register. So all those standards have to be maintained, but at the same time, how do we adapt to the new reality the virus has thrown to us? So a lot of work was done at JCIE, so the Joint Colleges Intercollegiate Exam Office, and many of you have started to get more involved with JCIE as you come towards the end of your training and you're starting to apply for the exam, and you're looking at all the information that they've been pushing out over the last few months. And it's been changing. It's been changing on a regular basis, but we're nearly there now on delivery of that. Lots of discussion with JCIE had with the likes of ASSET and BOTA, which would be the training representative groups across the UK and Ireland, and that sort of input, understanding the challenges, how to deal with it, very, very important. So a lot of very, very strong communications actually occurred, which probably didn't actually happen until, of course, we had to deal with the crisis. So that's been very useful. So the exams will go to commence next week, and a number of the specialties will be delivered over November, early December, and then there'll be about half of the other specialties then will be delivered in January. At the moment, the model, of course, is to deliver the exams in a hotel setting in Glasgow and in Edinburgh. And however, that's had a big impact on what about the Irish-based trainees and the travel restrictions that exist. And early on, we identified this with JCIE, and RCSI suggested that actually we will run the exams in Dublin remotely at the same time as the examiners are delivering the exam in the UK, and that way we maintain the same standards, the same exam panels, all the structures that are there, but we don't have our own trainees travelling to the UK. We did consult with the HSE on this, as whether there would be a derogation on travel restrictions, and that wasn't really encouraged by the HSE. So I think we just have to say, look, let's make the quick decision here and we'll deliver this remotely. So people would have received communications from JCIE. So essentially, JCIE are still running the exam. The college is facilitating the location as such and the technology to deliver the remote exam. We will also be using Irish-based examiners as invigilators, not as examiners, more just to make sure everything is done right, answer any questions, be able to feedback to the quality assurance team in JCIE in the UK that everything went according to plan and standard and so on. So there's a lot of work being done in the college. Actually, I was in there today myself, and this week kind of getting essentially the nitty-gritties of cables, laptops, Wi-Fi boosters, and you name it, into a place where we have to try and make sure that there's none of the technical hitches, and that the everyone can just get examined in as well a setting as we possibly can. As you know, the exams, of course, will involve no patients this time. There will, of course, be the usual oral stations and the clinical stations, but no patients will be used. I mean, that's to minimise the whole issue of, I guess, transmission of the virus and those sort of risks. All of this has been agreed with the public health teams in Scotland and Scottish Government in order to deliver it. And if everything stays as they are, and everyone's observing the restrictions that are being there at the moment, and there's no serious or urgent deterioration of the virus status in Glasgow, the exams will be delivered next week as planned. And that's good news, because I mean, delivery of our exams are dependent on the Glasgow exams going ahead. Otherwise, we don't have the examiner panels to deliver on that. So as I said, the same number of stations, same structures are there for the oral stations. You'll be using paired examiners. There'll be obviously the specific designated topics that are used and examined on the day. There won't be any exam assessors. There won't be any examiners in training, and there'll be no externs either. And that's obviously to minimise the number of people that we have to have involved in the exams. As I said, no patients for the clinical stations. There'll be all clinical scenarios. And the non-questioning examiner can and is encouraged to act as kind of role play. So, you know, if there's kind of help with the communications. So things like if you're asked, you know, take us through the consent and risk conversation you might have with a patient when undergoing a lap chole or whatever. The non-questioning examiner can just be that person you talk to, which makes it a little bit easier to give your answer, I think. So that's the sort of approach that will be taken on the delivery of on the day. There will be also obviously we're probably all used to it now. You'll have to do a COVID declaration that you haven't been positive, you haven't been in close contact, you haven't been sent for testing within 14 days. There'll be a temperature check taken on the day, and we just, I mean, everybody is, we've seen with the Part B exams and the membership exam, everyone will be incredibly polite, incredibly compliant. They understand things are a bit more awkward and clunky, but nonetheless, they all have to be done in the best interest of getting the job done, and that's been very useful. So there'll be a number of kind of different things that will happen at the venue, sign in, but the surgical affairs team will be there to support people throughout the day anyway. So essentially that's really it. There'll be the examiners and the invigilators in Ireland will have a session with JCIE, I think, on Thursday and tomorrow, and that's to sort of take them through their paces on that. I'll send it out again. There was a very, very good presentation made at a webinar from John McGregor on the format of the exam and information on that, and that's where I got all my answers, by the way, as well. But we'll send that link out after this to anybody, and we'll send it out again. I think we sent it out already to all the trainee trainees in different specialties. So again, that we can send it out for information. And of course, as always, if there's any questions or concerns, you just ring into surgical affairs. The team there will take the question, and we might know the answer straight away, but we'll find out somebody who does have the answer and get back to everybody there. But so far so good, and fingers crossed it'll all happen. It kind of just has to happen. You know, we have a lot of people who are worried about their CCST. There's been enough interruption to everything this year. They're also planning fellowships, and they need to have the exam done in order to be able to go and take up that fellowship position in the summer. So there's a lot at stake, and every effort has been made to deliver it, David. So hopefully that's giving you a flavour anyway of what's going on.
Thank you very much, Kieran. So we'll move on to our panel discussion. Darren, Orla, and Catherine, you might come back on the call. I have a couple of questions that came through during the registration process, and I might start with Darren. Darren, would you say the impact of COVID-19 on your training has been viewed as an opportunity for development or more detrimental?
I think it's a combination of both, really, David. Certainly, initially we all identified the negative aspects, but as things progressed, the advent of more online teaching and it functioning extremely well, I think has been a huge positive outcome. As I mentioned during my talk, we have a formal online teaching program now, and there's every centre with vascular has 2 dates in the calendar year to present, and it's a pre-specified topic, so you can read around the topic in advance, and it's very much case-based. So, we find that very beneficial, and I think that would never have come about without COVID. So certainly that's positive. And having weekly teaching sessions is a huge plus, as opposed to more kind of days dotted throughout the year, maybe one a month. In addition to that, you don't have to travel. So, a couple of my training years have been outside of Dublin, so in Galway and in Cork, and certainly having to take the day to travel does really add to the difficulties getting to these training days, and you're missing out on operative lists, etc. So, you can still go to your list, you can go to your clinic, and then have the training in the evening afterwards. So I think that's a huge plus.
Brilliant, thank you, Doireann. Orla, I was going to ask you, by putting trainees on COVID-19 duties, and I don't know if that happened to you or any of your colleagues, are we going to create poorly trained surgeons?
I think that's an interesting question. I think that at the moment, as far as I'm aware, there aren't any current trainees redeployed. I might be wrong on that, but from the repeat of the survey, we didn't have any trainees currently on redeployment. In the initial survey, we did have trainees who had been redeployed to other areas. The majority of these had been redeployed to either kind of anaesthetic areas or to ICU-based care. So I think that, technically you could argue that there is definitely scope for learning new skills, particularly in kind of the anaesthetics ICU scenario. And some of the trainees who were redistributed to those areas did make those comments that, yes, they may have missed out on certain things, but they became more confident with airway management or kind of blood gas management, which is obviously a big advantage. Personally, from my own point of view, during the initial wave, I was redistributed to, I was still within a surgical service, but redistributed to a more kind of direct ED role, which again, my actual operating cases would have dropped off, but I got more experience in terms of kind of, I suppose, being discharging patients, seeing more patients on their initial presentation, rather than having a patient kind of presented to you who has already had a certain amount done. So I think generally for trainees who are driven, there's always opportunities for learning. And luckily, I think as we've gone forward, the amount of trainees that are being redeployed has definitely reduced as well, and will hopefully be minimised going forward.
Thank you, Orla. Prof, did you want to come in there?
Yes, thank you. Just to reassure all the trainees that the HSE is aware at the highest level of the impact COVID has had on the training numbers. It's reassuring to see that the number of cases at this in recent weeks has returned to almost levels, but the impact on training has been made very clear to them. And we've had support from the Medical Council, who've also written to the Minister for Health along those lines, and supporting the view that if there is to be substantive outsourcing to the private sector, that arrangements should be made where possible, that trainees should follow the potentially training cases. So we're very aware of this issue, and we are voicing that to HSE, and we have support from the Medical Council.
That's great news. Thank you, Professor O'Connell. Just because we're running short on time, Catherine, I might give you one last question, if that's okay. Do you feel like you missed out, or you're missing out on something by not going abroad for your fellowship?
Yeah, I mean, that's a really obvious question, I guess, and one that people have asked me for sure. I think that, as Professor O'Connell said, the structure of CLEFT is really unique. We have in the UK and Ireland really led the way internationally in terms of centralising service to a small number of high volume units. And so I think that for that reason, fellowship training within this system is sought after and certainly would be my preference. Being in the unit where I had trained previously and planned to work in the future meant that I could hit the ground running, and I was working with people who knew my ability and trusted me from the get-go. So I was able to start off as first operator in the procedures I was doing from day one. And I don't think that would have happened if I'd gone elsewhere. I think in terms of the overall experience of living abroad, that for sure is a wonderful opportunity. I was really fortunate that I did a year of my research in Boston in a big academic teaching hospital and was able to access the clinical teaching activities as well as the research side. So I was privileged to have benefited from that, and I think that experience contributes to my experience going forward as well. So yeah.
Great. So I don't see any questions in the chat. So we're going to wrap it up. Oh, sorry, Kieran, go on.
Yeah, David, just to say well done and thanks. And I have to say that the presentations were extraordinarily good as always, of course. But the information on the study on what happened in the period of the COVID high period, if you want, and then seeing some sort of a recovery, really informative, really useful. During fabulous presentation, I think on the work, and I know Sean and Oscar and those and Donica and Dara looking at that data. So it's really important how valuable, of course, it is to have that information and data available. Is really interesting. Survey was excellent, really informative as well. One of the things I that's really we forgot about the actual cancellation of all of our conferences and academic sessions, and the fact that people get to present their abstracts. I guess to sort of help them, I guess more confident for people to get to know them better. That's actually been a big loss. It's something I hadn't really appreciated, to be honest with you, until you presented there tonight. So we're going to have to do something about that. I know we're planning to have a virtual charter in February. And we'll have a number of sessions there, and I know the specialties themselves will be organising their own sessions there, so that'll be probably a good opportunity, I think, for people to think about the structure of those. And I know, David, you're organising the usual ISTG session on the Saturday as well, which again will be very important. So look, we're happy to help at all in surgical affairs where we can organise these events, organise any of the virtual presentations, because it actually is very, very important for everyone's development and to get those opportunities. So yeah, that was great, and just so thanks a million for having me along tonight as well. So appreciate it.
Thank you,
David,
Kieran. You're always welcome. Go on,
if I might just echo that, and thank you all of our trainees for your commitment and your hard work and your professionalism, and it really has held the health service together. So we're very proud of you, and we look forward to maybe having a couple more of these training sessions on Wednesday evenings. So thank you very much.
Thank you.
Thank you all, and good night.
Thank you.
Night, everyone.